Thank you, Dr. Zhu. That was a fantastic introduction. You have already covered my title slide, so we don't need to spend too much time on it, but that's exactly right. I'm going to be talking about augmented intelligence and anatomic pathology and what I think the implications of it will be for our future careers as we go forward here. Let me see if I can switch over and just move in. Disclosure statement. Okay, back up real quick. I do not have any financial relationships with any ineligible entities. I don't own any stock directly in any of the companies that I may mention, although it may be a part of some mutual fund holdings I have in personal retirement accounts. Okay, what we're not going to be talking about, sometimes it's worthwhile to just kind of mention ahead of time the limitations of the conversation. So a lot of times when people think of augmented intelligence, artificial intelligence, we think of synthetic human-like intelligence. For example, maybe AI, or if you want to get a little bit more grimmer, the Terminator series. I'm not going to be talking about that. I'm not going to be talking about generalized human-like intelligence. I'm not going to be talking about some of the contemporary concerns that have arisen around the potential for social changes caused by hyper powerful artificial or synthetic intelligences, things we might associate with science fiction scenarios like Ray Kurzweil's Omega Point, where you have a really powerful intelligence that becomes like a godlike being or a threat to humanity. We're going to try to confine ourselves to what we can be relatively more certain of, what's already happening, what's already unfolding, and the ways that the next couple of years are going to be affected by machine learning in pathology, and more specifically, rather than perhaps some of the broader social changes that could be introduced outside of the field of pathology. We're not going to be necessarily talking about as well how a lot of machine learning works on a technical level. So that means we're not going to be talking about a lot of things like neural networks, genetic algorithms, backpropagation, Monte Carlo trees, decision forests, other things that are associated at a computational level when it comes to creating these kind of machine learning systems. What we're not going to be talking about either is the distant future. And by the distant future, I mean much beyond a decade. The way that technology is progressing now, it can be very, very difficult to see what's going to happen in 4 or 5 years, much less what's going to happen in 20 years. So my predictions, I'm going to try to confine them to the next 10 years or so. Obviously 100 years in the future, a lot of things could be happening, which are far beyond anything I'm talking about right now. I'm also going to be confining my discussion to anatomic pathology. Whatever I say about anatomic pathology is going to be true as well in other senses for clinical pathology. It's just not an area of pathology in which I'm particularly active and do not have enough personal or professional experience to speak confidently in. Before we proceed, a few definitions. Mostly what I'm going to be talking about is machine learning as opposed to artificial intelligence. And machine learning, just to give a definition, is a field of study that's concerned with the design and development of algorithms and techniques that allow computers to learn. And what it does is it represents a shift away from symbolic understanding towards probabilistic analysis. By symbolic understanding, we might mean a machine that can take instructions in a linguistic or visual form and then abstract them out to execute processes. For example, you engage in symbolic communication whenever you tell Siri to send a message to someone. You're giving a communication in symbolic or linguistic form, and the instrument is taking, or the machine is taking that, interpreting and performing an action. Symbolic learning would be when you attempted to teach someone by symbolic expression, telling them, for example, if you have, a pigmented lesion in sun damaged skin, you need to be concerned for, melanocytic neoplasia. That would be symbolic instruction. And currently, machine learning does not involve symbolic instruction of computers. Computers understand, and algorithms are taught by other means through statistical and probabilistic analysis of large quantities or large sets of data. And this is also referred to as deep learning. And this is accomplished through a model of passive observation rather than active agency. In other words, these algorithms process large quantities of data that is presented to them passively. They do not interact with the world and then get a response and then learn from that response, and then interact with the world and get a response and learn from that response. Digital pathology. Digital pathology is also going to revolutionize the way we practice within the next decade. And I think we can all see that coming. And I'm going to be talking a little bit about this in the talk as well. And what that is, just the integration of digital and computing technology into clinical practice of pathology. Augmented reality. Augmented reality is the merging of a real-time environment and digital information to provide a kind of supplementary integrated view of information. And augmented intelligence is a concept as differing from artificial intelligence, is a conceptualization of artificial intelligence that focuses on the assistive role of machine learning, emphasizing the fact that it can assist human cognition rather than replacing human cognition. Okay. Again, machine learning in this talk will be focused as a black box. We're going to be thinking about inputs into the system and outputs into the system, and not necessarily how these systems work. Many of them are proprietary, and much of what we think of as security within these extremely valuable technology companies is when they are protecting the proprietary function of their machine learning algorithms. So much of this is not publicly available knowledge, and even if I did know it, I would probably not be allowed to communicate it with you. Okay, so just a brief timeline of some achievements in machine learning. It's probably worth recognizing, just quickly looking at this graph, that there are several, that machine learning has progressed in intervals. There are a few periods of a lot of activity, followed by a number of lulls in which there was not much development going on. Early machine learning was with early computers. Turing proposed, of course, the possibility that computers could learn, and he created the Turing test, which most of us are probably familiar with at this point from science fiction, if nothing else. Arthur Samuels developed early machine learning programs, including a computer that could play checkers, and popularized the term machine learning. After that, through the 60s and much of the 70s, there was very little development in machine learning. 1979, the Stanford cart is a relatively famous experiment that occurred kind of towards the end of that interval, in which essentially involved a very crude robot that could navigate its environment and learn about new environments. Starting in the 1990s, people began to become interested in machine learning again, particularly in the late 1990s when Deep Blue defeated Garry Kasparov at chess, which was long believed to be a kind of virtually unattainable summit of machine intelligence. And since then, things have actually progressed relatively quickly. Watson beating human beings in Jeopardy in 2011. The Google Brain team, which was able to leverage large quantities of data from information uploaded to YouTube, was able to develop an algorithm that could identify cats on video. Image processing for recognition of objects was considered to be an extremely difficult task, in the late 90s and early 2000s. 2014, Facebook did essentially the same thing with DeepFace in terms of facial recognition for human beings. And of course, AlphaGo. It was long believed that, although once chess had been conquered, it would take, decades for computer processing to reach the point where it would be able to process a game like Go. And it actually, took, less than 2 decades. So a lot of this is happening much more quickly than was initially expected. However, if we look at the history of machine learning, we see as well that there are long lulls in it as well. Enablers of machine learning. Big enablers of machine learning, the reason that advances in processing power, parallelization, and transfer speed. So a lot of this is driven by better computers. So we have able to fit more transistors onto a chip. We're able to network computers more quickly with the gigabit Ethernet connections. And that just this year increase in quality of computer hardware has assisted this. In addition, this advances in learning algorithms, which I'm going to skip over just a little bit. As well as to be paired with this enablers of teaching. So really what we have are better and better computers on one hand. And on the other hand, we have the ability to train them better and better. And where does a lot of that teaching come from? Well, part of it is advances in data storage. In parallel to advances in computing speed, we're having advances in hard drive capacity, computer chip capacity. We can store more and more data in smaller and smaller volumes. This is allowing us to create huge data sets, which previously just did not exist. And through sheer repetition, these data sets can be used to train algorithms. The other side of this, of course, where a lot of these data sets are coming from is the internet, which began to become popular civilian use in the late 1990s outside of academia. And with the development of social media, you have individuals uploading large quantities of information to various social media companies. This information, famously can be data mined for the training of machine learning systems. And that is where a lot of it is coming from. We are just storing more and more data and putting more and more stuff online, allowing greater and greater data sets to be created. Of course, the real enabler behind all of this is money, right? With these data sets, these machine learning algorithms, you can do various tricks, in terms of advertising, targeted advertising. There's a lot of cash behind this in the end. So the fact that the computers enable it, these data sets enable it, and there's a lot of money to be made in it, pretty much guarantees that there are going to continue to be advances in machine learning development into the future. Just briefly, what inspired this talk? In my previous life, I shouldn't say my previous life, in my undergrad career, I was actually an electrical engineer, and I did play around in the late 1990s with machine learning. Back in those days, what we were doing is hardware-enabled machine learning with field programmable gate arrays. And a lot of that is a hardware implementation as opposed to a software implementation of machine learning. That turned out to have a lot of limitations, in that a lot of the stuff we were working on turned out to be completely specific to the computer chip that it was being run on. You could train a computer chip to do a number of interesting machine learning-like functions, but then you tried to transfer that configuration to another computer chip and it would not work. So realization of machine learning algorithms digitally as opposed to in hardware has turned out to be a critical element of it. The other thing that inspired this talk, well, obviously, this has been a conversation that's been going on in the pathology community for a few years, but when I was at Walter Reed, one day I had an O4 show up at my doorway, and he had a couple of Google scientists in tow with him, and they were asking for a tour of the Histology Laboratory, which I ended up giving them and spending a number of hours in conversation with them. And that is a project that was actually driven by this O4 and his conversation with some Google engineers who are a friend of his. And one day this O4 mentions that the Joint Pathology Center has over 4 million cases sitting around in an archive somewhere, and you guys are always looking for data to train these machine learning algorithms. Do you think you might be interested in this archive? And that kicked off the whole ball of what we are looking at right here, which is a Google Augmented Reality Microscope. From Google's perspective, having access to this archive of more than 4 million cases was obviously appealing for training of machine learning algorithms. From the perspective of the Joint Pathology Center, is also appealing as well. It's been a goal of kind of military medicine for a long time to try to find ways to facilitate or to support pathologists that are working in isolated professional environments, which is to say you have a single pathologist overseas, far away from any kind of subspecialty support. They have a difficult case. What are they going to do? And for decades now, Walter Reed and the Joint Pathology Center have been working with telepathology, trying to develop that, ways of transmitting images back and forth. At one point, there was even a completely automated microscope where a pathologist could sit at a computer and control a microscope remotely and just view the images through the microscope on the screen and attempt to provide real-time consultation services. Digital pathology has also been an interest of them as well. And, the augmented reality microscope, in other words, maybe having some automated processing as well as something that appealed to the Joint Pathology Center. So that's what we're looking at right here. This is a microscope, obviously. You can see on the back that there's a camera. In addition, there's another notable difference between an ordinary microscope and this microscope, in that kind of in between the stage and the eyepiece, you have an additional structure right here. And that is a small projector that will actually project images into the field of view of the microscope. So you can see in real time images overlaying on the microscope field of view. just kind of give you an idea as well, it's connected to a computer. So what ultimately happens is you put a slide onto this microscope, and the camera will read the slide, send the image to the computer. The computer will provide an interpretation, and then will project that interpretation in the pattern of green lines onto your field of view through the microscope. And you can actually see kind of a little bit about how the computer is thinking about things as well, or the computer is viewing the system as well. And this is the computer interface that kind of sits next to the microscope. You can see that currently this is very much an alpha system. We have 2 tissue models that we're looking at, and those are lymph node and prostate. We have 2 magnifications that we're looking at, and we have some brightness adjustment, and that is basically it. The system will try to interpret based on what is coming through the microscope. And you can see here that we have it on the prostate setting, and we're viewing a prostate needle core biopsy. And the system is highlighting an area of concern right here. And we can see the area of concern does contain some tumor, but they're not just tumor. It's highlighting some additional areas as well. And we can see on the right side of the screen the heat map, which is what the machine learning algorithm is registering as the area of greatest concern for abnormality, or in this case, neoplasia within the core. Okay, let's back up real quick. Okay, and as an engineer, when I first get one of these systems, the first thing I try to do is break it, because that's the only way to really learn about how the system is working. So I just start putting some other tissue under the microscope right here. This is what the prostate algorithm thinks of a kidney, for example. So there it is, interpreting a normal kidney. It's still very much an alpha. As you're going through the system on the prostate algorithm, you can see that this system really likes to highlight atrophy and identify atrophy as invasive carcinoma. Now, I guess that could actually be carcinoma, but it looks like atrophy to me. So you can get an idea that perhaps simplified glands of any type are triggering the algorithm. In addition, there's also areas where high-grade PIN is incorporated. And as we can see, the cores on the right side of the screen, the upper core, there's some high-grade PIN and tumor that's being highlighted. And in the lower core, it's just a benign core. And the reason we might be actually having some issues with stuff being mishighlighted is that the algorithm, at least with this system, this alpha build, is not robust to a lot of different changes. You'll notice here that the mishighlighted core on the lower right-hand side of the screen is kind of peripheral. It's not necessarily as well illuminated as the central core. And the algorithm did not seem robust to illumination changes. You could change the illumination under the microscope, and visibly the screen would adjust to that, and your eye would of course adjust to that, but the algorithm was unable to adjust to it. So this is the same core, just with 2 slightly different luminosities. You can see in one, there's some high-grade PIN and tumor that's being highlighted, and the other, there's no highlighting going on at all. Another example here of 2 different situations. On the left side, we have a higher level of luminosity. On the right, we have a lower level of luminosity. The photographic imaging software can adjust for that. Your eye can adjust for that. But the algorithm with a lower level of illumination misidentifies large sections of these cores as tumor. It's also not robust to changes in focal plane. Just a slight change in the plane of focus will cause the algorithm that's highlighting tumor on the left side to miss tumor once it's shifted slightly out of focus. And just to play with it a little bit more, I actually took a number of other tumors that the system was not trained on and ran them through the algorithms to see what it would make of them. And you can see some examples here. This is actually a pretty typical example of what we do see here at the VA. There were 2 settings. There's one for lymph node to look for metastatic lung cancer in lymph nodes, and one for prostate. And you can see that the prostate setting identified the colonic adenocarcinoma readily. Actually also identified carcinomas with ductal and papillary morphology quite well. Less so carcinomas with solid type morphology. Which to me seems interesting because you can begin to get an idea of what the algorithm might be triggering on. If it's trained on a broad variety of prostatic tumors, then it's going to be recognizing abnormal glandular structures, but it's also probably going to be recognizing cribriform structures as tumor as well. And I strongly suspect that's the case. If you look on the right side, you can see an example of colonic adenocarcinoma being processed through the prostate algorithm. And you can see that the prostate algorithm does a good job of highlighting the cribriform structures of the invasive colonic adenocarcinoma. Just some other examples as well. We can see on the right side, we have a papillary renal cell carcinoma, and the prostate algorithm is actually doing a pretty good job of highlighting that as well. But you can see the morphologic overlap between that and perhaps a Gleason pattern for prostatic adenocarcinoma. Another example would be, although the algorithm was certainly not designed to evaluate for lymph node metastases in the prostate setting, the prostate setting was still able to identify a focus of papillary carcinoma, papillary thyroid carcinoma within a lymph node. So there is some generalizability as well. The algorithms clearly worked differently, though. You can see on the left side, colonic adenocarcinoma in the prostate setting. On the right side, we have colonic adenocarcinoma on the lymph node setting, which would, in theory, look for adenocarcinoma or non-small cell carcinoma metastatic to lymph nodes, and it's not recognizing the tumor at all. That's essentially an arbitrary pattern there. So going forward, kind of big question here is, aren't we already doing this in pathology? And the answer to that is yes. And we've been using algorithms to assist with diagnosis for some time. And anyone who's cytology or GYN pathology has probably been shouting at the screen for this entire lecture. There's nothing new in that respect. When it comes to interpreting Pap smears, we were working with attempting to automate that process as far back as the 1950s without digital technologies, just implemented in electronic image recognition patterns. Cytoanalyzer was kind of the first example of that, and that basically was just an attempt to use analog electronics to recognize nuclear hyperchromasia. The Japanese were working with that in the 70s as well. In the 1980s were attempts to essentially automate Pap smear analysis digitally. Moving up into the 1990s, the first one that was FDA approved was TriPath in 1998, and that was sold to a number of high-volume laboratories. It was acquired by Becton Dickinson and became the BD Focal Point Slide Profiler. Kind of famously, it was allowed to sign out a certain percentage of cases, 25% of cases, as normal, and then reclassify the other 75% into a number of categories for further review. Currently, progress is continuing. ThinPrep has started working on a system that was FDA approved in 2003. It was acquired by Hologic in 2007, and Hologic is currently working to validate it as a Hologic Genius system. And they have that system in clinical trials that are currently expected to wind up in December of 2022. So this is something that has been happening in pathology all along, particularly in cytopathology. So in some sense, this isn't new. It's just like many things, it's getting to the point where it's becoming sensible to bring it into kind of wider scale use, both beyond, cytology and in more than just high volume practices. And the forces at play are obviously technological advancements. We've talked a little bit about them before. Regulatory bodies, and of course, economic realities. And economics, defines what is truly possible in all of this. Diving into technological limitations. There's a nice paper out here in Nature Medicine that came out in 2021 looking at generally at machine learning and augmented intelligence in medicine overall. And they looked at 130 different devices which were FDA approved, none of them within pathology. So we are far behind in many ways other areas of medicine. In particular, they looked at a case study of imaging and chest X-ray interpretation using machine learning, I should say, probably augmented intelligence. And they created an algorithm they created a number of algorithms for machine learning to interpret chest X-rays for pneumothorax. And these systems were trained on 3 data sets at 3 different institutions. Notable were significant decreases in accuracy when these systems were used outside of their training environments. So these systems were trained on 3 separate institutions. When the algorithms were used within the institution that trained them, they functioned quite well. When the algorithms were used at institutions outside of those that trained them, then you saw a noticeable decrease in accuracy. And that highlights the need for prospective studies and evaluating these and subsequent performance reviews, but also points out an important limitation of this, which is extreme data set sensitivity and machine learning algorithms based on deep learning, which is the reason frequently why such enormous data sets are needed for machine learning. When Google was training its cat recognition video systems, it was training them on tens and tens of millions of videos in order to achieve this degree of accuracy. This is just an example here. Hopefully, you guys can see it of kind of the accuracy of the algorithm both within and without the system. So you have Stanford Healthcare System, NIH, and my brother Brigham and Women's was the other institute where it's being worked at. And you can see that the algorithm's accuracy drops noticeably. The Stanford system at Stanford, accuracy is 0.9, so 90% accurate. Once you shift it over and start using that same algorithm at Brigham, it drops down closer to 80% accuracy. And NIH, it was even below that. And a similar pattern held all the way across the algorithms. Once they were used outside their environment in which they were trained, there was a noticeable decrease in accuracy. Another technical limitation that we deal with here, a few years ago, MD Anderson started to attempt to adapt IBM's Watson for oncology. And the idea would be that the Watson system, which was trained obviously to play Jeopardy, would analyze essentially the totality of oncology literature and incorporate that information into making recommendations for patient care. And I stuck a quote on here. The big struggle that has come out of this, that's been realized at MD Anderson, is that these systems are not symbolic learners. And there's enormous power in that, and that they can process vast volumes of information. But in medicine, including pathology, we often find ourselves in a situation where the field will change radically overnight. It could happen, somebody publishes a paper or several papers, and a new entity is created, WHO publishes a new edition, suddenly the field is revised, and that information is communicated symbolically. You have one paper, the paper explains the diagnostic criteria for the new entity, you change your practice recommendations based on that. Machine learning algorithms that function probabilistically based on data sets find themselves struggling to update their diagnostic categories and their treatment recommendations, if they're actually giving treatment recommendations on the basis of this new information. They update their learning algorithms slowly as information accumulates over time. And this was a big issue when it came to training Watson for interpreting oncologic papers, because you would have a new paper that come out that would have substantial implications for patient care, and yet it would be just one paper. In terms of the data set, it would just be one paper among millions and millions that were going into the algorithm. And getting the algorithm to appropriately prioritize it and revolutionize, or to change its recommendations in a timely manner is a challenge. So this is a strong limitation of non-symbolic augmented intelligence. Just to dive in as well on dermatoscopic technical limitations, dermatoscopic recognition of melanoma. This is a wonderful paper as well. It's not directly pathology related, but much of this research is going on outside of pathology as well. And this is a good paper just because it kind of illustrates some of what we talked about earlier when we were diving into the Joint Pathology Center Google Microscope. What they discovered when they took an algorithm, they trained it on a curated image set of melanomas, and then took that information, and it seemed to work beautifully on the curated image set, and then took non-curated image data and ran it through the algorithm, and they noticed a dramatic drop in performance. They also noticed that, for example, if you took a single image and you ran it through the algorithm, if the image was oriented in one direction, the algorithm might predict it to be melanoma, and you change the orientation a couple of times, and suddenly the algorithm is predicted to be a nevus. So these algorithms, again, struggle with robustness to various transformations, and they frequently struggle with robustness outside of their training data sets, which just makes the importance of recognizing the training data set all the more critical. Anatomic pathology, though. Okay. So there have been a couple of groups that have looked at training deep learning algorithms for classification anatomic pathology. There was one group that looked at classification of colon polyps based on whole slide images, and they developed a training set of 2,000 images. They split about 90% of these images, used those images for training, and then they took the several hundred images that were left over, and they ran those images through the algorithm, and they achieved 93% accuracy within the 6 diagnostic categories that they were using for colon polyps, which is quite good. Also, as well, another group did something similar to automated diagnosis of lymphoma. They had a training set of, again, nearly 2,000 images, split off about 90% of those, used those to train the algorithm for one of 4 different categories of lymphoma, essentially Hodgkin lymphoma, non-Hodgkin lymphoma, reactive lymphoid process, and I can't quite remember the last one. I think diffuse large B cell was one of them. And they, again, achieved 95% accuracy within these 4 diagnostic categories, but recognize, again, these are very broad-based diagnostic categories. Again, and it's also been used in a perhaps more research-based issue as well. Machine learning has been used as in order an attempt to predict outcomes in non-small cell carcinoma and glioma, and perhaps, a little bit closer to Dr. True's heart, urothelial carcinoma. And there have been a number of papers published in which machine algorithms were taken. Large data sets of images were processed through, and then the machine would correlate those with outcome and then attempt to predict outcome based on, being presented with a case as well. And it was discovered that these algorithms were able to do so within certain limitations. Oftentimes, there was an attempt to understand exactly what the algorithm were doing in these circumstances. And in some cases, they were able to figure out what it is. And oftentimes, it was things like changes in cytoplasmic tincture or changes in chromatin texture that the algorithm seemed to be subtly picking up on and using for its predictions. So these are things that would not necessarily be reproducible by human pathologists. Human pathologists is, if we're looking, one person on a scope versus another person on a scope, a subtle change in the texture of the chromatin, which may actually have prognostic significance, is not necessarily something we're going to be able to consistently diagnose with between each other and often, between ourselves from case to case. Machine learning is a predictor of molecular features as well. That's something that I think we're going to be seeing more of. Again, this is predominantly within research data sets, and machine learning in the diagnosis and graded prostate cancer. Again, that's something that Google and the Joint Pathology Center were looking at. And this is something that's actually been validated on some rather large data sets, and machine learning algorithms have proven to be quite good at this. Nepal and his group looked at machine learning in terms of validating learning algorithm for improving Gleason scoring. And they used a rather large data set, and they went back retrospectively and were able to find a number of, and were able to demonstrate that it was effective in grading prostate cancer, and even in one circumstance, discovering a tumor in a previous case that was thought to be benign. Okay, reliance on retrospective training. So this is a big technical limitation. All of this training is done on pre-existing data sets, and there are often struggles with generalizability from these data sets. These data sets don't necessarily the algorithms trained on these data sets don't necessarily translate from institution to institution, much less more broadly in terms of thinking of training for one tumor type to cover another tumor type. Oftentimes, the cases in which these are most effective are cases with a limited diagnostic spectrum. When you do a prostate biopsy, you essentially have one question in mind: is there tumor or not within the prostate biopsy? There's much less prostate biopsy done for inflammatory processes. Colon polyps as well, pigmented lesions. These are things in which there's a narrow diagnostic differential. Narrow diagnostic differential means it's much easier to get comprehensive data sets that are large in size. Broadening the diagnostic differential means you might need much, much larger data sets that include many, many copies of each entity that you want to teach the machine. That begins to be much, much more challenging when you deal with pathology more broadly, especially when you deal with entities in which there may only be a couple of dozen or 100 known cases in existence. Regulatory limitations. Machine learning patterns cannot be explicitly understood or communicated. This is a big issue. These algorithms do not come with internal instructions as to how they work. This makes it difficult to know exactly the circumstances in which they are going to succeed and the circumstances which they're going to fail. This necessitates a very in-depth validation process. Bias due to training sets is a big issue as well. And this can be bias that is introduced by all sorts of factors. Even subtle differences in staining can introduce bias in training sets. If the training set is trained on a hematoxylin that stains acidic mucins, or is an iron hematoxylin as opposed to aluminum hematoxylin, this can have effects on the overall interpretation of the slide by the computer system. And finally, of course, diagnostic categories undergo constant development, and they often shift very rapidly. If you're a hematopathologist, you're familiar with suddenly having everything completely revised overnight and having to learn a completely new system and having that happen multiple times throughout your career. This kind of thing is challenging enough for human pathologists, but machine learning and deep learning algorithms are fundamentally unable to make these kind of rapid diagnostic adjustments in the way that symbolic thinking allows human beings to do. Okay. Regulatory limitations. We have no regulatory framework for machine learning and pathology, and that's going to be a big barrier to developing this going forward. A lot of this comes down to considerations of diagnostic spectrum. How broad are we looking at the instruments of diagnosis? Are we looking at an instrument that is going to recognize prostate cancer? Or are we looking at an instrument that is going to take any kind of biopsy from any tissue type within the body and recognize any kind of disease process? There are no standards for vendor development right now. What kind of requirements are vendors going to need to make in order to develop these algorithms? Are they going to need to what institutions are they going to draw from? What kind of databases are they going to have access to? How much information are they going to need to incorporate? None of this has been established yet. No standards for validation, not just for validation. If you're going to bring one of these instruments, hypothetical machine learning algorithms, into your practice, what are we going to need to do in order to prove that it's safe to use in practice and that it works within the tissues that you are and with the specimens that you're going to be presenting it with? No standards for establishing a quality assurance. These machine learning algorithms are going to need to be treated like pathologists because they are, in a sense, making diagnoses. So that means there's going to need to be quality assurance performance of that. How is that going to be done? Are we going to be doing human quality assurance of machine learning algorithms? How is the vendor going to be involved in that? Certainly the vendor is going to want to know whether there's an issue with the performance of their algorithm. That means that the vendor may need access to patient data in order to make that decision, which often means the vendor is going to need images of patient specimens, is going to need to know correlating diagnoses. That raises issues as well. Legal responsibility for diagnostic errors, of course. The vendor is going to have much deeper pockets even than the pathologists or the large practices. So there's going to be a lot of concern as to who pays. Should there be a diagnostic error? Is there ultimately going to be a signing out pathologist that's responsible, or is the machine learning algorithm going to cause the company that's selling these systems to be responsible as well? None of that has been decided. Multiple regulatory bodies will obviously need to be involved. FDA, CLIA, College of American Pathologists, etc. Again, essentially what's technically possible is probably even less important here than what is economically feasible. We think of, laboratory spending in general. Laboratory spending is around 2.5% of healthcare costs as recently as 2017 when I was able to find my data. Anatomic pathology spending is a fraction of that. We're looking at probably about 1% of total healthcare costs. And that's 40 to 50 billion annually, which sounds like a lot of money, but it's a fraction of what we're spending on radiology. And by comparison, you're aware that Tesla is training machine learning algorithms to drive vehicles. The US auto market is a $1.2 trillion market. So this is far less money that is being this is a far smaller market than automated driving, and yet in many cases it's as sophisticated a task as automated driving, and often has a significantly higher risk associated with it. So we have high value return versus low value return technology. High value return expands functionality, and low value return simply replicates an existing function. So are these machine learning algorithms going to give us additional functionality within pathology, or are they just going to provide another way of doing what we're currently already doing? High value reduces costs. In other words, high value increases efficiency of practice. Low value doesn't. Low value gives you very little change in costs, and yet you're paying for a system. Example of a promising system, which again, clearly when you look at it, has a lot of value to be associated with it, yet implementation of it is often pretty challenging, is of course the electronic medical record. You look at the advantage of having an electronic medical record are superficially obvious, and yet the challenge of implementing this, in spite of the fact that it's clearly a high value technology, gives an example of the way things may be going when it comes to implementing machine learning and pathology. Digital pathology is another thing to consider, splitting it off from machine learning and pathology. Excuse me. Okay. Digital pathology is a perhaps much higher value return. The advantages of being able to make diagnoses off of electronic images as opposed to glass slides should be obvious, given that many pathology practices are having to cover multiple hospitals involving pathologists traveling around, perhaps working in isolation in different hospitals, and the ability to transfer images back and forth as opposed to slides for diagnosis, primary diagnosis, for consultation, for quality assurance are obviously enormous enough. And the question is machine learning going to add much over and above digital pathology to make it worthwhile in its implementation? And finally, a word on ethics. I say this for the end. This is far from the most important topic. Machine learning requires very large data sets. These data sets come from actual living human beings who are our patients. And these data sets essentially have to be repurposed from patient care. So these are not specimens that are taken for the purpose of educating the machine. These are specimens that are taken for the purpose of providing a diagnosis to a living human patient. And they have to be repurposed to educate the machine. Surveys show that patients are often significantly uncomfortable with the idea that their data may be repurposed. There's not a lot of awareness among the general public for how pathologists use tissue outside of the diagnosis. Patients know that, they got a biopsy, that a pathologist read it. Patients don't necessarily know that their tissue is sitting in a wax block in a basement of a hospital somewhere. And when it comes to their general level of comfort with the idea of a for-profit corporation taking images of their slides and using them to train algorithms, which will then be sold for profit, oftentimes surveys have shown that patients show some degree of discomfort with that. This discomfort also shows significant demographic variability. There's an excellent survey of patients at Veterans Administration facility asking them, and there is, depending on race and gender, there's often a lot more distrust of the system, and this is something that needs to be taken into account. Commercial usage without direct benefit to the patients, who are the ones that are essentially donating their tissues to the education of these instruments, raises significant ethical questions. We are probably very much aware of the whole situation with HeLa cells, and this potentially, is substantially larger than that. And the fact that these instruments may be used to educate machine learning algorithms, which could then be repurposed commercially, could bring about significant backlash from patients to the extent when they become aware of this inevitably. Ownership of diagnostic specimens, which is to say that the slides and blocks that we have in our laboratories has never actually been established, either by courts or by statutory law, which is to say our right to do whatever we want with these tissues and blocks has certainly never been established. Who owns the images, even the anonymized images? Who owns the tissue, even the de-identified tissue, has never been determined. One begins to suspect that this is not going to be a situation that is going to be remain undetermined for much longer. And of course, there's always the issue that training data may not be representative. I bring up the Joint Pathology Center here. They're the system they work for the system I was created with earlier, but the Joint Pathology Center Joint Pathology Center, remember, is a federal government system. And so a lot of its archive comes from the US military and VA hospitals, which may not be in their patient population representative of the patient population as a total within the United States. Some of the other larger archives in the country, which may end up being used for training archives, such as the Mayo Clinic, which would have one of the larger ones as well, also probably does not draw from the United States randomly. Their demographics of Mayo Clinic patient are probably substantially different from the demographics of the American population as a whole. And the fact that this could bias training sets is something that we need to keep in mind. And of course, the fact that companies that are developing for machine learning for pathology will need or want access to ongoing clinical data in order to provide quality assurance for their algorithms. So it's going to be more of a situation of if at some point the practice implements these algorithms, the company is going to want continuous feedback in terms of the performance of the algorithm, which will often require access to clinical data, patient information, diagnostic information, and in some cases, possibly even outcome information, depending on the intention of the algorithm, or correlation with other laboratory studies, again, depending on the intention of the algorithm. So to bring everything together, technical limitations. Cases with a broad versus a narrow differential diagnoses. A lot of the stuff that we're seeing right now in terms of the utilities algorithms, we're seeing them applied both in research and in limited clinical studies in situations where the differential diagnosis is relatively narrow. We're looking at prostate biopsies for cancer. We are looking at colon polyps. There is a limited set of diagnoses that are provided for the vast majority of these cases. Also, we need to consider rare versus common worst case diagnoses. If you have a prostate biopsy, you have a very narrow differential diagnosis. It's essentially neoplastic or non-neoplastic. With the neoplastic category, the worst case diagnoses is, again, a relatively narrow set. You're almost always just dealing with adenocarcinomas. If you want to take another example, look at a gastric biopsy. The vast majority of your gastric biopsies, in contrast to your prostate cancers, prostate biopsies are going to be benign processes, frequently inflammatory or reactive. However, in rare circumstances, not anywhere near the vast majority of circumstances, there may be a sigma ring cell carcinoma showing up within a focus of the biopsy. And those are rare worst case scenarios. And training machine algorithms to recognize rare worst case scenarios is more challenging than training machine algorithms to recognize common worst case scenarios. And yet it's the worst case scenarios that are driving most of our concern for these biopsies. Anatomic pathology is an intrinsically multimodal specialty. This is something we're all aware of. All of the cases I've talked about for machine learning are diagnostic anatomic pathology, but diagnosis is only a part of what we do. We also do staging. We also do quality assurance for surgeons. And in order to fully practice pathology, you need to be able to interpret gross reports. You need to be able to perform gross evaluations. Machine learning algorithms are not at the point where they can read a gross report, extract, slide A7 is the deepest invasion of the tumor, go to slide A7, identify the tumor, measure its depth of invasion. That requires symbolic processing, which again is beyond the functionality of most algorithms. So when we speak of machine learning and pathology, we're speaking of it being essentially right now confined to diagnostic image processing within a relatively narrow set of cases that have a narrow differential, and the worst case diagnoses are relatively common. Economic limitations. Anatomic pathology is not entirely about the microscope. Much of the money that goes into anatomic pathology is actually associated with the technical component of slide processing and creation. It's not necessarily the time you spend in front of the microscope. Of the professional component, the substantial component of that is actually the grossing of the specimen, which again will not be performed by the algorithms at this point. And then there's the general overall relatively small market size of anatomic pathology compared to other things, not just U.S. automotive industry, but within medicine itself. Radiology being a good example. Regulatory changes. Sudden changes in diagnostic categories, these algorithms, as I pointed out earlier, cannot shift on a dime. If you want to imagine a situation, imagine having a automotive driving algorithm that is driving cars around the road, and one day the United States government changes so that all cars, are to be driven on the opposite side of the road, English or Australian style. and how the algorithm would suddenly become completely dysfunctional, and yet there would be no way to update it. Human beings would probably struggle with it as well, but we would be a little bit faster to update than the algorithms would. And of course, the access to ownership of patient medical data required for continuous training quality assurance is going to create substantial challenges for corporations in developing these algorithms. Predictions, again, trying to look out not much more than 10 years here. Okay, so machine learning is augmented intelligence. So these algorithms are going to come into practice, but they are not going to replace pathologists. Rather, what they are going to do is provide us with an expanded palette of functionality. In addition, we're going to see more and more of using them as a research tool. And this image analysis is going to be incorporated into pathology as a research tool in conjunction with genomics, proteomics, and of course, analysis of RNA expression, and attempt to classify tumors to develop prognostic, better ideas of prognostic prediction. And we're going to see much more of this in the next decade than we are going to see of clinically applied augmented intelligence and machine learning. Watch other fields. Anatomic pathology is far behind other areas of medicine implementation of machine learning. Radiology has a lot of overlap with anatomic pathology in the sense that it relies on image recognition for diagnosis. And yet there's more money spent in radiology than there is in anatomic pathology, which means there's more of a drive to implement machine learning in radiology than anatomic pathology. So my recommendation is if you want to see what the future is for anatomic pathology and machine learning, keep an eye on the field of radiology. It will happen there first in terms of clinical practice. And finally, the legal status of diagnostic tissue specimens is not going to remain in limbo indefinitely. At some point, it's going to be established a system for how these images and how this clinical information can be utilized, which incorporates not just the need for technological advances in this area, but also incorporates the need to respect patients, patient autonomy, and the interests of patients. Okay. And this is just quick text on, I'm going to shift gears a little bit and talk a little bit about the Histology Laboratory and how I think probably the Histology and Anatomic Pathology Laboratory are going to change as we go into the future. I'm sorry for those of residents that are watching today and are having horrible flashbacks seeing the image on the left side. This is our Anatomic Pathology or Histology Laboratory at the Veterans Administration Hospital. On the right side, we have a chemistry analyzer. And just looking at the two, you can see on the right side, the chemistry analyzer is a completely integrated system. A blood tube comes at one end. The blood tube is taken. The information is read off of a barcode, and the specimen is processed and entirely hands-off in an automated way. On the left side, specimen comes in at every level a human being is handling it. This is radically different between the two. And my prediction is what we're going to see more and more is that the histology laboratory is going to come to resemble the chemistry laboratory. The necessity for machine learning algorithms to have consistency in staining of tissues is going to mean that more and more in the future, as these algorithms are incorporated, we're going to have histology laboratories being purchased, in a sense, in block from a single company that is going to provide the stain or is going to provide the reagents, is going to validate it, and is going to make sure that everything from the water chemistry, the choice of hematoxin is exactly matched to optimize to be working with the digital slide scanning system and with the machine learning algorithms that can be providing assistance and interpretation. So you'll buy a block instrument or a block series of instruments can link together. The slides perhaps come in one end unstained, they go through automated stainer, they go through automated cover slipper, they go through automated scanner, and then they come out the other side and the glass may go into a file. Again, there are even large systems that are used for embedding biopsies. At some point in the future, we may see systems that, at least in large scale laboratories, do simple embedding and cutting as well. So the laboratory, the histology laboratory, which is kind of the last part of the laboratory to automate, is going to be progressively automated as we go forward. And it's going to be more and more of a manufacturer's playground as opposed to kind of a chemist's playground. Slide digitization is absolutely going to happen. That's happening right now. This is the GT450 system that we're set up at the VA that we're going to be validating soon. Of course, you are validating over at Harvard, you are validating your own slide digitization system. The advantages of slide digitization are simply too enormous for portability and to facilitate image analysis in order to ignore. Digital environment versus the microscope, just briefly diving into this. Big advantages of digital environment. Portability, obviously, is one. Notation, it's much easier to make notes on digital slides. It's much easier to measure on digital slides. It's a completely controlled imaging environment, which is to say that brightness and plane of focus can be completely controlled, which eliminates a lot of the variables that machine learning algorithms have been struggling with. It also allows pre-screening. In other words, what can end up happening is you have your slides go into the automated system, it stains, it cover slips, it scans them. The digital slide is then pre-screened based on the type of tissue it is. If there is a certain threshold of probability, for example, if a breast biopsy goes to a system recognizes a breast biopsy, if the system says, okay, there's a 98% chance that this is a malignant breast biopsy, and there could be a threshold set saying, if there's a 95% or higher chance, then we're going to go ahead and pre-order these additional stains, ER, PR, HER2 stains on the specimen. So the slide could get stained up at 4 or 5 o'clock in the morning. The algorithm could analyze it. The system could pre-order the slides at 5:30 in the morning, or pre-order the immunohistochemical studies at 5:30 in the morning. Those could be performed, and by mid-morning you could be sitting there, and you will have the breast biopsy. You can see it, and you will have already pre-ordered, your ER, your PR, your HER2. You can sign out the entire case with all the complete information essentially from the start. So the advantages of pre-screening are potentially high. Virtual multicolor immunochemistry provided by machine learning algorithms. You could have an immunohistochemical study in which the tissue specimens are automatically aligned with one another, allowing you to see co-expression of different markers, which has a lot of utility frequently within hematopathology, creating a kind of virtual multicolor immunohistochemical slide. Automated quantization. Automated quantization has been happening for years and years and years. There's nothing new about that. But the advantage of having your ER, PR, HER2 automatically quantized really would help with standardization and taking off a little bit of kind of useless additional scout work from anatomic pathology, and of course standardized grading as well. There's always a subjective element to grading lesions, and having a system that would provide standardized grading, for example, for renal neoplasms, for standardized or assist with standardization of prostate grading, would facilitate standardization in the field of pathology, which would of course just make us more accurate in our predictions. Drawbacks of the digital environment: resolution and field of view. Just diving into here quickly, the microscope is obviously a lower resolution environment than the digital screen, but one thing people often don't think about is field of view. When you are looking for a microscope, a much higher percentage of your field of view is absorbed into the vision of the microscope than when you're currently watching this presentation, for example. When you're in the microscope, you're talking probably about 60-70% of your field of view, and certainly the binocular aspect of your field of view is completely absorbed within the microscope. Whereas when you're looking at a screen right now, probably 20-25% of your field of view is this screen, and that's if you're relatively close to it. The effect of this is that if you're trained in a microscopic environment, you generally get used to having a much larger percentage of your field of view being absorbed by whatever it is you're looking at. And as a result, when you switch over to screen view, you attempt to replicate the same size of this specimen on the screen as it is presented in percentage of your field of view on the screen. So if you had a prostate biopsy and the prostate biopsy was 10% of your field of view when you're looking at the microscope, on the screen it's going to be much, much smaller. So as a result, often pathologists, as they transition to interpreting slides on a screen, will find themselves zooming in. Most of us are probably going to interpret pathology biopsies at 40 power. But when you're on the screen, the immediate instinct is to zoom up to as high magnification as possible to make the image on the screen occupy the same percentage of your field of view as the image did when you were looking through a microscope. And a lot of this adaptation is going to be psychological, but it doesn't necessarily have to be. We do have virtual reality headsets which have been developed, which allow you to essentially replicate the microscope field of view within a virtual reality environment. So at the very end, I'd like to wrap up just by having a day in the life of a future pathologist. So this may be, what some of our residents are living in a few years. So you wake up in the morning, get out of your bunk bed, you grab your cup of delicious coffee, you sit down at your desk, which is not actually, going to be a sitting desk. It's going to be a standing desk. We're going to be healthy today. And you put on your virtual reality goggles, and you immerse yourself in a digital environment, and you have a pre-screened slide in front of you. We'll have this as a prostate case. And the slide will have an area of interest highlighted, and it will say, say adenocarcinoma, grade group 1, and 13%. It'll pre-quantify it for you. So you look at it and you say, okay, I don't quite agree with that. And you adjust the interpretation. You highlight the areas where you think the actual tumor is, and the system recalculates for you. And then, of course, generates that and produces it and shifts it into a report and pre-generates a report for you. You approve the report, you sign it out. All from the comfort of your standing desk. Okay. And with that, hopefully I'm wrapping up. I hope I didn't take too long and too much of everybody's time. Questions, comments?
I'd like to lead off, David. There's a lot of interpathologist variance in diagnosing as well as grading different lesions. And it makes me concerned about using even a consensus of pathologists to define what the truth is. And so to what degree should the clinical parameters, clinical outcome of a patient be used as the reference point to a diagnostic system that works?
This is, that is an extremely important question. The way that machine learning algorithms have been trained in the papers that I've looked at have been overwhelmingly by looking at pathologic diagnoses, not at patient outcomes. And I think that that's an important point. And I suspect that going forward, we're going to be seeing that as a research question. As to where we're going to go in terms of training these algorithms for clinical use, it's going to throw an additional challenge into training the algorithms if we're going to be attempting to get clinical information and use that to correlate and create the diagnoses. So I suspect that what we're going to see a lot of in the next decade is going to be the use of these algorithms in research, where it's much easier to correlate with clinical information. On much smaller data sets, but this is going to allow us to find significant elements within the images, or significant histologic elements that are more, I guess you can say, that the algorithms can identify more reproducibly than human beings, and yet have significant clinical implications for the patient. So we could end up where, an algorithm looks at a colon cancer case and splits it into 40 different categories based on imaging features that human beings can't reproducibly identify. And how we end up validating those out, we're certainly going to have those algorithms within the next few years for research purposes. How we validate them for clinical use is going to be a significant challenge. It's going to be a significant challenge.
Okay. Yeah. Thanks, Dave.
Okay. Thank you, Dr. Tree. For using, and I have another question as well. For using AI for making diagnosis or detecting a certain lesion, what is the currently required sensitivity and specificity? The answer is there isn't one, and nor is there any guidance from the FDA on this. Again, that's one of the things that is going to be slowing down this process as we go forward, is the fact that we are proceeding in essentially a void here. None of this has been developed, and it's going to have to be developed as we go. In terms of what's required sensitivity and specificity, who knows? Who knows at this point? Dr. Alpers, how do these AI diagnostic systems stand up with differentiating cancer from preneoplastic or atypical cancer lesions versus cancer, no cancer? Overwhelmingly, the situations in which these algorithms are being experimented on right now is in cancer, no cancer. I have not seen any papers discuss atypical or near cancer lesions. Obviously there's these kinds of questions just highlight the enormous fertility of the field for research purpose or for research going forward. But overwhelmingly, the papers that I've seen published are all cancer versus no cancer. And in some circumstances, as Dr. True pointed out, trying to see if predictive information or predictions can be made on histologic appearances for patient outcome. I have not seen anything for use of algorithms in borderline lesions, at least in my literature review so far. So again, enormously fertile field for future research. And Dr. Alpers, again, what do you think are our own institutional barriers, VA and UWI, to more rapid deployment testing, efficiency of digital pathology, AI approaches to anatomic digital pathology? I'm not sure how much I can answer for the University of Washington there. I think the VA, one of the major limitations is going to be the privacy of patient information. And the VA is highly sensitive to this. For obviously historical reasons, there have been a couple of well-documented instances where patient information, vast quantities of patient information were lost or made public. And the administrative repercussions of that were severe. The VA is highly sensitive about sharing its patient information with other sources, and it's definitely sensitive about sharing it with private companies. And this is going to impair implementation of these kind of machine learning algorithms within the VA system. That would affect, machine learning aspects of it. Digital pathology, I think the barriers to that are probably a little bit lower. In fact, I think that the advantages to it are such that we're probably going to see more institutional push towards these systems rather than resistance to them. Information security is always going to be an issue. That's always an issue anytime you're transmitting, protected patient information across the internet or through, any kind of electronic means. But that's something that with the electronic medical record, we've had that long enough to have somewhat of a handle on the risks associated with information security. So I think there's actually going to be a push towards digital pathology. In terms of machine learning, though, I think at least within the Veterans Administration, it's going to be somewhat inhibited, perhaps reasonably, by patient privacy concerns. And also concerns, of course, for exploitation of veterans. And then we have a question from Dr. Schulpers. Another difficulty of the difficult digital pathology experience thus far is the software. Yes, very much. Okay, so the software is crude, to say the least. It is like using, it is definitely limited. Moving on the slide on the microscope feels fast, tactical, obviously. Meanwhile, when you're using the software, you're trying to navigate with a mouse. It's slow, it's awkward. You can only see a fraction of the information that you can digest when you're looking through a microscope as opposed to with your hands. The answer is there aren't really any better interfaces out there. I did, bring up the virtual reality environment, and virtual reality environments need digital interfaces as well. And those exist, and those are distinct from the interfaces that are used, for example, for the mouse and keyboard. And some of the virtual reality interface devices, which are essentially almost like handheld joystick devices, are probably much more amenable to the practice of anatomic pathology than the mouse and the keyboard. Because you can, have your left hand navigating the slide, and your right hand, you could have a thumbstick which would adjust the magnification. And so, because we don't have to worry about focal plane anymore with these, with digital slides. So we're not going to need to focus anymore. We can just have, perhaps one hand dedicated navigation and with, with the appropriate hardware interface and, one hand dedicated magnification, and you're dictating to a voice recognition program that can handle the diagnosis. So without too much work, one can imagine such a system, but the reality is I have not seen it implemented in software yet. It's one of those things which there's enormous demand for. And again, there's a gap. And if there's a gap, it's going to be filled. And I think there's a lot of potential there for people that are interested in it to dive in and perhaps create, systems which are somewhat based off the microscope, or maybe in your left hand, you have little dials that you can use to move the image. And in your right hand, you have another dial that you can use to adjust magnification, and you can work off a system like that. That would essentially mimic the smoothness of the slide interface. But you're exactly right. In addition to field of view, the fact that a lot of these interfaces seem to be designed by somebody who's thinking of pathology as being much closer to manipulating an image on Photoshop or Microsoft Paint as opposed to a microscope slide is definitely one of the problems with the system. Okay. Any questions at this point? Any other questions? Thank you, Dr. True. And thank you for everyone that attended, and best wishes to the residents as well. We're all going to be living this future together.